Hi everyone. Today let us talk about the topic of vocal cord paralysis, part 1. Okay, in this topic we are going to talk about the questions that were asked in the previous years from this chapter. If you have to understand vocal cord paralysis, whether it is unilateral recurrent laryngeal nerve palsy, bilateral recurrent laryngeal nerve palsy, unilateral complete palsy, that is both superior laryngeal nerve and recurrent laryngeal nerve, or bilateral complete superior laryngeal nerve palsy. What happens in these palsies? Without having a good grip over the relevant anatomy, you cannot make sense of what is going to happen in these things. So I'm going to talk a little bit about the relevant anatomy. We are going in the relevant anatomy. We are going to talk about the intrinsic muscles of the larynx and their function, the nerve supply of the larynx, and after we do this, we are going to talk about briefly what happens in a case of unilateral and bilateral recurrent laryngeal nerve palsies, the scenarios, what is happening in these things. Now, these are just terminologies. I guess most of you will know it. What is abduction of the vocal cord? Abduction of the vocal cord. The vocal cord is moving away from the midline. Suppose these are the vocal cords. The vocal cord is moving away. The vocal cord is moving away. Okay, this is the right side. This is the left side. This is the new position of the vocal cord. So if the vocal cords are moving away, we call it abduction. When does it happen? When you have a deep inspiration. In deep inspiration, the vocal cords move away. Okay, suppose these are the initial position of the vocal cord. They move away so that the air can go inside. Adduction of the vocal cords. Adduction means coming close together. Coming closer to midline will be the better word, better line. They are coming closer to the midline. Suppose these are the vocal cords. Now he is breathing. Now he wants to talk. They come close together. Okay, when they come close together, the vocal cords will be able to vibrate with each other, among each other, and produce speech. So this happens during speech. So adduction is when the vocal cords come close to the midline. Abduction when they are going away from the midline. They are going away from the midline. Okay. So if you remember this, what is abduction of the vocal cord? What is adduction? Abduction is moving away from the midline. Adduction means moving close to the midline. In abduction, the space increases. In adduction, the space between the two vocal cords increases. In adduction, the space between the two vocal cords decreases. Tensing and relaxing the vocal cord, this is obvious. When we have to speak or we have to modulate the voice, it can be tensed and then relaxed depending on what we want to speak. Okay. So there are certain muscles which cause abduction. There are certain muscles which cause adduction. There are certain muscles which cause tensing and relaxing of the vocal cord. And there is also something called inlet of the larynx. Okay. The inlet of the larynx is formed by these epiglottis, the ariepiglottic folds, the arytenoids and the intra-arytenoid area. This is which leads into the supraglottic area, which we talked about in carcinoma larynx, the supraglottic area. It's also called the vestibule of the larynx. After that comes the true cords, that is the glottis, and then comes the subglottis. Okay. So there are muscles which open the inlet of the larynx, and there are muscles which close the inlet of larynx. This is mostly in terms of, when you swallow food bolus, it should not be going into the larynx and it goes into the esophagus. Okay, so when you open the inlet of the larynx, air goes in. When you close the inlet of the larynx, the vocal cord, the epiglottis comes in contact with the arytenoids, so that the larynx opening gets effectively closed off. At the same time, the false cords also close with each other, touch each other and close the opening, and also the vocal cords also come together to close the inlet of the glottis. Okay, that becomes the rima glottis. Okay, so this is another part of it. Now coming to the muscles of the larynx and their action. The first muscle that I am putting first is the posterior cricoarytenoid. Posterior cricoarytenoid, you please focus and give more importance to posterior cricoarytenoid. Now, where is this posterior cricoarytenoid? Posterior. It is posterior to the cricoid cartilage. This is the cricoid cartilage, okay? And it is present posterior to the cricoid cartilage. And from cricoid, where is it going? It is going to the muscular process of the arytenoid cartilage. So it is in between the cricoid cartilage and the arytenoid cartilage. Where is it present? Posteriorly. So this muscle is in between the cricoid cartilage and the arytenoid cartilage. And when this contracts, what happens? The arytenoid will move like this. Okay, it rotates laterally. The vocal process of the arytenoid moves laterally, causing the vocal cord to abduct, or move away. So what it is posterior cricoarytenoid among all the muscles is the only abductor that we have, is the only abductor of the larynx, of the vocal cords, the only abductor of the vocal cords. See the significance of it. Okay, so this is called the safety muscle of the larynx. Safety muscle of the larynx. Why is it called the safety muscle of the larynx? Because if this suppose does not function, by something happens and the posterior cricoarytenoid does not function, the vocal cord cannot be abducted away. The patient or the person cannot breathe. Okay, cannot breathe. The air, the oxygen will not go into the lungs. It can be potentially fatal. Okay, so posterior cricoarytenoid is the only muscle which abducts the vocal cords. Okay, because it abducts, you get a space in between the two vocal cords so that air can go in and which can save the person's life. So this is called the safety muscle of the larynx. Okay, I'll repeat, posterior cricoarytenoid is the only abductor muscle of the larynx. Only abductor. Rest of the muscles are they are adductors. Now coming to the second muscle, that is the lateral cricoarytenoid. Lateral. It is present laterally. It is present laterally. Okay. This you can see. This is the cricoid cartilage superior border. So this muscle is coming right here. This is present laterally, and it is connecting the cricoid cartilage to the muscular process of the arytenoid. This is the arytenoid. This is the muscular process. This is the vocal process. This is the body of the arytenoid. So it's connecting what? It's connecting the cricoid cartilage with the arytenoid cartilage. So when this contracts, what happens? When this contracts, what happens? The vocal process of the arytenoid moves medially. So lateral cricoarytenoid vocal process moves medially. Okay. When it moves medially towards the midline, medially means towards the midline. Which means what happens? It adducts the vocal cord. Adducts the vocal cord. As we just talked, adduction means bringing the vocal cord close to the midline. See here, both the vocal cords have come together. This is the arrow that they are showing. So there it is causing both the vocal cords to get coming closer together, coming closer to the midline. So this is an adductor of the vocal cord. It adducts the vocal cord. If you observe, it is adducting both the vocal process of it is bringing both the vocal process of the arytenoid together, thereby bringing the vocal process together. But you are still having a space in between the two arytenoids that is brought together. Okay, so suppose if the lateral cricoarytenoid functions, then you will have both the vocal cords are coming together, but both the arytenoids are still far away from each other. Okay, so that function, the bringing together of both the bodies of the arytenoid together, is done by the transverse arytenoid. So it is causing adduction of the vocal cords, which is causing further adduction of the vocal cords, and the space you see in between the two arytenoid bodies are also brought together. So if the transverse arytenoid functions, both the arytenoids, so this is the arytenoid, this is the arytenoid, and both the vocal process are already brought together by the lateral cricoarytenoid. The transverse arytenoid will bring these two together and close the entire vocal cord. So vocal cord, as we know, it is having one membranous part and the cartilaginous part. The posterior 1/3 is called the cartilaginous part. The membranous part, from where the vocal process starts, where the vocal cord is attached to the vocal process of the arytenoid. This part, where this is the body of the arytenoid, right? So suppose this looks like this. So this part will be brought together, both the arytenoids will be brought together by the transverse arytenoid. It's also called interarytenoid, but let us just remember transverse arytenoid. So it is bringing both the arytenoid cartilages together. So it is causing adduction of the vocal cords. So transverse arytenoid and cricoarytenoid both are causing adduction of the vocal cord, whereas posterior cricoarytenoid, it is abducting the vocal cord or bringing the vocal cords away from each other, away from the midline. So that is the only abductor. The rest of the two muscles are adductors. Now coming to cricothyroid. Cricothyroid is a very special muscle because this is the only muscle which is supplied by the superior laryngeal nerves, external laryngeal branch. Okay, we are going to talk about it in the nerve supply. Rest of all the muscles that we are going to talk about, whether it is the posterior cricoarytenoid, lateral cricoarytenoid, transverse cricoarytenoid, thyroarytenoid, thyroepiglotticus, the rest of all the muscles of the larynx are supplied by the recurrent laryngeal nerve. So cricothyroid is that special muscle which is supplied by the external laryngeal nerve. So in recurrent laryngeal nerve palsies, cricothyroid will get spared. So what is cricothyroid? That's why cricothyroid is so important. What does the cricothyroid do? So suppose, this is the thyroid cartilage. Okay, this is the thyroid cartilage. Inside the thyroid cartilage, we can see the arytenoid and we can see the vocal cord, which is connected, which is attached to the medial, medial surface of the of the thyroid cartilage in the midline. Okay, when this is a cricothyroid muscle, it has got two parts. So this is the anterior part, this is the posterior part. Both of them contract together as a single muscle. When they contract, what happens? The entire thyroid cartilage is being pushed forwards. Okay, there is this membrane in between the cricoid and the thyroid cartilage. This membrane is called the cricothyroid membrane. The cricothyroid membrane also shortens in size, and the entire thyroid cartilage is pulled forwards. Entire thyroid cartilage is pulled forward because of the action of this cricothyroid muscle. So this was the initial position. Now this is the final position of the thyroid cartilage. So it is moving away. So what happens to the vocal cord? The vocal cord moves away. It lengthens, L-E-N-G-T-H-E-N, lengthens the vocal cord, thereby tenses the vocal cord. When you pull something away from each other, it tenses the vocal cord. So this is a muscle which tenses the vocal cord. There is also another function of this cricoid cartilage. In the absence of other muscles which are going to stop it from action, suppose all the muscles are going to act, we do not call cricothyroid as an adductor. But according to Wagner and Grossman theory, the cricothyroid, probably in the absence of other muscles which are acting, will not only tense the vocal cord, it also adducts the vocal cord. This is according to the Wagner and Grossman hypothesis. We are going to come to that. So basically, what does the cricothyroid do? Cricothyroid is in between the cricoid cartilage and the thyroid cartilage. It pulls the thyroid cartilage anteriorly, thereby lengthening the vocal cord, thereby causing tension or tensing the vocal cord. And it also has an additional function of adducting the vocal cord. Okay, so this is what you have to remember about the cricothyroid. And cricothyroid is the only muscle which is not supplied by the recurrent laryngeal nerve. It is supplied by the external laryngeal branch of the superior laryngeal nerve. Okay, now coming to thyroarytenoid muscle. Thyroarytenoid muscle in between the thyroid cartilage and the arytenoid. So this is present just lateral to the vocal cord. Okay, when this contracts, what happens? The vocal cord will become relaxed. Suppose this is the vocal cord. Okay, on the left side, there is this muscle which is present laterally to this vocal cord. Okay, when this contracts, the vocal cord will become relaxed. Okay, vocal cord will become relaxed. Okay, let us not go according more vocalis. One small point if you want to remember, vocalis is that part of the thyroarytenoid. Suppose this is the thyroarytenoid, this is the vocal cord. The medial most part of the thyroarytenoid muscle is called the vocalis. It is described that the medial part of this, that is the vocalis muscle, the anterior fibers have some attachments to the vocal cord anteriorly, and when this vocalis muscle will contract, it tenses this part and it relaxes the rest of the vocal cord. So it is modulating. So it is useful in singing and when you want to change the voice. So basically thyroarytenoid, you just remember thyroarytenoid and vocalis, they relax the vocal cord because they are present lateral to the vocal cord, and when they contract, the vocal cord relaxes. Okay. Now coming to the muscles which open and close the laryngeal inlet. So this is, as I talked about, this is the laryngeal inlet. Okay. So here we have the epiglottis, this is ara-epiglottic fold, this is arytenoids. Okay, going into it, this is the vestibule of the larynx. Thyroepiglotticus, it is present between the thyroid cartilage and the epiglottis. So when it contracts, what happens? The epiglottis opens like a flower. Okay, so the opening, it causes opening of the laryngeal inlet. Opens the laryngeal inlet. Ara-epiglotticus between the arytenoid and epiglottis. So you have the oblique arytenoid, inside you have the transverse arytenoid, on top of it in the form of an X mark you will have a oblique arytenoid that continues forwards to form the ara-epiglotticus. They are the same muscle essentially. So when they contract, you see this is the arrows they are showing together. When the ara-epiglotticus contracts, the two lamina, the two parts of this epiglottis come closer together, causing closing of the laryngeal inlet. Okay, so these are the muscles of the intrinsic muscles of the larynx. So let us have a quick recap. So first we said there is something called the posterior cricoarytenoid. This is the only abductor. It is present posteriorly. Okay, between the cricoid and the arytenoid. Next we talked about the lateral cricoarytenoid. It is present laterally. Okay, it is attached to the muscular process, and when it contracts, it causes pushing both the vocal process of the arytenoids together, causing adduction of the vocal cords. When lateral cricoarytenoid contracts, still there is this part of the vocal cord, what's it called, the cartilaginous part of the vocal cord, that is still far away from each other, so that the triangle part is still left open. Now that is contracted by the transverse arytenoid. Transverse arytenoid will bring both of these together, both the arytenoids together, causing adduction of the vocal cord. Then we said cricothyroid. Okay, cricothyroid is a special muscle, as we said, and remember, as much importance as you give to posterior cricoarytenoid, because it is an abductor. Cricoarytenoid is special because it is supplied by the external laryngeal branch of the superior laryngeal nerve. So because this muscle will get spared, all the muscles are gone in rectal laryngeal nerve palsy, cricothyroid is left behind. What does cricothyroid do? It pulls the thyroid cartilage towards the cricoid cartilage. Okay, anteriorly, thyroid cartilage is moving anteriorly, causing lengthening of the vocal cord, causing tensing of the vocal cord. It is also having an adduction function according to Wagner and Grassmann theory. So that causes the adduction and tensing of the vocal cord in unilateral or bilateral recurrent laryngeal nerve palsy, causing the vocal cord to come to the midline. We are going to talk about it later. Okay, so cricothyroid is very important. After cricothyroid, what did we learn about? We learned about the lateral thyroarytenoid. Yeah, we talked about the lateral thyroarytenoid, and we talked about vocalis. Both are the same muscle. Actually, they are present just lateral to the vocal cords, and when they contract, the vocal cord will become lax or relaxed. Okay, then we talked about thyroepiglotticus. Between the thyroid and the epiglottis, it is opening the laryngeal inlet. Ara-epiglotticus, which is a continuation of the oblique arytenoid, it is present between the arytenoid and the epiglottis. When it contracts, it closes the laryngeal inlet. Okay. Now coming to the nerve supply of the larynx. Remember this part, larynx, the entire larynx is supplied by the 10th cranial nerve, the vagus. That means whatever it is, the sensory innervation is also by the vagus, and the motor innervation is also by the vagus. So whatever the larynx has sensory supply, both the sensory supply above the level of the vocal cord, below the level of the vocal cords, it's all supplied by the vagus. And also the motor supply, all the intrinsic muscles of the larynx are supplied by the vagus nerve. So both, that's what I mean when I said the entire larynx is supplied by the 10th cranial nerve. That means the entire sensory and the motor innervation is by the vagus only. No other nerve participates in the functioning of the larynx. Both the sensory part, suppose you are eating something and the food is being prevented from going into the larynx, it is the vagus that is doing it. Suppose you are talking, it is the vagus that is doing it. Okay, both of them are done by the vagus. Okay, two branches, it gives two branches. So vagus has two branches. So one is the superior laryngeal nerve, it has got two branches, the external laryngeal and the internal laryngeal branches. It's the superior laryngeal nerve. Okay, there is the superior ganglion of the vagus, inferior ganglion of the vagus. Okay, fine, it comes down and it gives one branch, that is superior laryngeal and the recurrent laryngeal. Now we are more interested in the superior laryngeal nerve and the recurrent laryngeal nerve. Okay, two branches. So this is the lateral view. So this is the base of the skull, superior ganglion, inferior ganglion. It is giving the superior laryngeal branch. This is the internal laryngeal and the external laryngeal, and this is the recurrent laryngeal. Okay. So this is on the right side, this is on the right side, and this is, we are going to talk about it now. Next. Now coming to the superior laryngeal nerve branches. Superior laryngeal nerve, as we said, is a branch of the vagus. It is given superiorly. Then after the superior laryngeal nerve comes out of the main vagus nerve, it gives one branch that is called the external laryngeal branch. The external laryngeal branch goes forwards and supplies the cricothyroid muscle. As you can see, this is the cricothyroid muscle. It is going from the cricoid cartilage to the thyroid cartilage. So it is supplying the cricothyroid muscle. So external laryngeal nerve is a motor branch. It does not have any sensory function. It's a motor branch and it's supplying the cricothyroid muscle. Cricothyroid muscle is special also because it is the only intrinsic muscle lying externally. All the muscles of the larynx you cannot see outside. Only the cricothyroid you can see outside. So cricothyroid muscle is supplied by the external laryngeal branch of the superior laryngeal nerve. It also has an internal laryngeal branch. This is the internal laryngeal branch. It pierces the thyroid membrane and goes inside, and the internal laryngeal branch is a sensory branch. It has no motor function. It is a sensory branch and it pierces the thyroid membrane and it gives supply to the sensory supply to the larynx and hypopharynx above the level of the vocal cord. So whatever vocal cords, the sensory supply above the level of the vocal cord, both the larynx and the hypopharynx is supplied by the internal laryngeal branch of the superior laryngeal nerve. Now coming to the recurrent laryngeal nerve. Recurrent laryngeal nerve has got a different course on the right side and the left side. Superior laryngeal nerve has got the same course on the right side and left side. So recurrent laryngeal nerve is special. It is having a different course on the right side, different course on the left side. On the right side, it is given at the level of the subclavian artery. So here we have the recurrent laryngeal nerve. It is coming down, and at the level of the subclavian artery, it is looping around the subclavian artery and passing in between the trachea and the esophagus to enter into the larynx. It enters the larynx behind the cricothyroid joint. So in the right side, it is given at the level of the subclavian artery. It is given at the level of subclavian artery. It is given at the level of the subclavian artery. Okay, on the left side. Okay, one more point. This is from the NEET PG point of view. This is important. NEET PG point of view. This nerve is there. It is coming, looping around the subclavian artery, and it is going upwards before entering into the larynx. Just below the cricothyroid joint, it is joining. Most of the times it is present in between the branches of the inferior thyroid vessels. If you have to remove this thyroid gland, we have to ligate these inferior thyroid branches. Only then you can remove it. And most of the times it is present in between. So as you can see here, this is the recurrent laryngeal nerve on the right side. It is present in between the branches. So these are some branches are present in front of it, some branches are present behind it. So it becomes a bit risky for the surgeon to ligate it. Without ligating these blood vessels, you cannot remove this gland on the right side. So you have to ligate it. And if there is more bleeding, to find this nerve, in that nerve does not, here to show you, it is in a very good, nice yellow color. But in the real life situation, it will not be in that color. It will be very difficult to differentiate this this nerve from the fascia. And because you have to ligate these, and some of them are present in front of it, some of them are present behind it, while ligating it, you may damage this right recurrent laryngeal nerve. Okay, most of the times it lies in between the branches of the inferior thyroid vessel. Sometimes it is present anterior to it, sometimes it's present posterior to it. So this is the anatomy of the right recurrent laryngeal nerve. Most of the times it is present in between the vessels, inferior thyroid artery, in between the branches of the inferior thyroid artery. Sometimes it may be present anterior to the inferior thyroid artery, sometimes it may be present posterior. Because it is present in between the branches of the inferior thyroid vessels, while ligating it in case of a thyroidectomy, you may damage it. So that is the applied anatomy aspect of it, and this is an important question. The right recurrent laryngeal nerve, most commonly, does it lie anteriorly, posteriorly, or in between the branches? The answer is in between the branches of the right side inferior thyroid artery. Okay, left recurrent laryngeal nerve. Left recurrent laryngeal nerve goes further down. So right recurrent laryngeal nerve is given at the level of subclavian artery. Left recurrent laryngeal nerve to come here. This is the left recurrent laryngeal nerve. It's going further down. Now it is looping around the arch of the aorta. After looping around the arch of the aorta, it has the same course in the tracheoesophageal groove, and then further it goes further to enter into the larynx at the level of the cricoarytenoid joint. So this is given at a lower level on the left side. Right side, L for lower, L for left side. You can remember like that. Right side, it is given at the level of the subclavian artery. Left side at the level of the arch of aorta. Left side at the level of the arch of aorta. At the level of arch of aorta. As I said, it loops around it, and then here it lies mostly posterior to the inferior thyroid vessels. That's what is written here. Here it is lying mostly. This is the recurrent laryngeal nerve. These are the inferior thyroid vessels. This is mostly posterior in 62% of the cases. Okay, in 62% of the cases, that is the majority of the cases, it will be posterior to it. Sometimes it can be in between, sometimes it can be anterior. So because of this variation of the anatomy, there is a chance to damage the recurrent laryngeal nerve when you are ligating the inferior thyroid vessels when you are doing a thyroidectomy. Okay, now what does the recurrent laryngeal nerve do? This is the important part. What does the recurrent laryngeal nerve do? Recurrent laryngeal nerve has both sensory and motor components. So sensory, it is supplying the larynx and hypopharynx below the level of the vocal cords. What did we say? Above the level of the vocal cords. It is supplied by the internal laryngeal branch of the superior laryngeal nerve. It pierces the thyrohyoid membrane and it supplies the larynx and hypopharynx above the level of the vocal cords. Recurrent laryngeal nerve, both sides, right side or left side, have the same function. Okay, now it has only a different course, but it has the same function. The function is the same. It is supplying the sensory supply of the larynx and hypopharynx below the level of the vocal cords, and motor supply all the muscles of the larynx except cricothyroid. Let it be posterior cricoarytenoid, lateral cricoarytenoid, or interarytenoid, or thyroepiglotticus, or vocalis, or thyroarytenoid. All the muscles of the larynx are supplied by the recurrent laryngeal nerve except the cricothyroid, which is supplied by the external laryngeal branch of the superior laryngeal nerve. Okay, so coming to the one of the points that I want to note here is the most common cause of unilateral and bilateral recurrent laryngeal nerve and external laryngeal nerve palsy is injury during thyroid surgery. So when we say the patient, there are cases where you are going to where the patients are going to come to you saying that I'm having hoarseness of voice. When you do a indirect laryngoscopy or a video laryngoscopy, you will find that the left recurrent laryngeal nerve is not functioning. There is a palsy of the left recurrent laryngeal nerve. This can be because of neuritis in most of the cases. Sometimes we don't know the exact cause. It may be idiopathic. That sometimes the patient are going to present to you like this. But most of the times when we say there is a recurrent laryngeal nerve palsy or there is an external laryngeal nerve palsy, it is because of thyroid surgery. So thyroid surgery is the most common cause of unilateral or bilateral recurrent laryngeal nerve and external laryngeal nerve palsy. In thyroid surgeries also, more prone to injury is the which one? The right recurrent laryngeal nerve. Why? Because it is more often intermingled in the branches of the inferior thyroid vessels. Just now we talked about that. So thyroid surgery is the most common cause of bilateral or unilateral recurrent laryngeal nerve or external laryngeal nerve palsy. In that also, the right-sided recurrent laryngeal nerve, there is a more chance of injury to it. Okay, right-sided recurrent laryngeal nerve, more chance of injury to it. Okay. Now coming to the scenario. This is where people get confused, and this is what is important. Till now, this was all theory. Now we have to apply the theory, right? In scenario 1, you have there was a patient with a right-sided nodule of the thyroid, solitary thyroid nodule. We performed a right hemithyroidectomy was performed on this patient, and the patient developed right recurrent nerve palsy. Patient has developed right recurrent nerve palsy. Patient is presenting with hoarseness of voice. What happens in such a scenario? Let us discuss. So right-sided recurrent laryngeal nerve is gone. So what does it mean? It means that right-sided, all the intrinsic muscles of the larynx are paralyzed except right-sided cricothyroid. Cricothyroid is supplied by the external laryngeal branch of superior laryngeal nerve. This is paired. So right-sided cricothyroid is functioning. So what does cricothyroid do? Cricothyroid, it tenses the vocal cord. We just talked about it. So it pulls the thyroid cartilage anteriorly. Causing lengthening of the vocal cord, causing tensing of the vocal cord. It is also having another function according to Wagner and Grossman hypothesis, that it adducts the vocal cord. Okay, brings it closer to the midline. So it adducts it. Along with tensing it, it adducts it. That means it brings it closer to the midline. It brings the vocal cord close to the midline. So you have this condition where this is the right-sided, this is the left-sided. Now this is the epiglottis. This vocal cord on the right side is paralyzed. It is almost very close to the midline. The left vocal cord is functioning, so this can move from here. This is in abducted position. It can come close to it. It cannot touch it immediately, but after some days, because of compensation, it can even touch this. It may be in median position, that is close to the midline, or a little bit in the paramedian position. This is the position of the vocal cord in right-sided recurrent laryngeal nerve palsy. So because of the action of the cricothyroid's action, the vocal cord will not be away from the midline. It will be close to the midline. But the other vocal cord is functioning. So the other vocal cord can abduct if the patient breathes. So there is no problem for respiration. Patient is not going to present in stridor. So what does this say? No other muscle to opposite action, so vocal cord remains in midline or the adducted position. Only cricothyroid is functioning, pulling the tensing the vocal cord, pulling it medially to make it come to the midline. Okay, but the other sided vocal cord is there, thank goodness, so it can abduct or move away. So there is no stridor or mild hoarseness of voice. So this is how the vocal cord will appear in the right sided. It will appear almost at the level of the midline. This one can be present here, this one can be present here, and it will be moving perfectly, but this one will not move. Okay, the right-sided recurrent laryngeal nerve will not move. So this is called right-sided vocal cord palsy, which is secondary to right-sided hemithyroidectomy. Okay, because the left vocal cord is doing its function, patient will not have any symptoms other than mild hoarseness. Mild hoarseness may be there. Okay, suppose now coming to the second scenario, which is the scenario for which the ENT surgeons or even the general surgeons are scared of. When you perform a total thyroidectomy for this patient. Total thyroidectomy means you remove both the lobes of the thyroid with the isthmus. Entire thyroid is removed. There is a chance that you are going to damage the right-sided recurrent laryngeal nerve and the left-sided recurrent laryngeal nerve. There is a chance, not that it happens. So there is a chance that the patient, and in this particular patient, he developed bilateral recurrent laryngeal nerve palsy. What happens? So same thing will apply again. Both sides, all the intrinsic muscles of the larynx are parallel except the cricothyroid, which is paired. Both sides cricothyroid are functioning now. Other muscles have gone. Other muscles are paralyzed. They are not functioning. What does the cricothyroid do according to Wagner and Grossman theory, and also according to what it does anatomically? What is its function? It tenses the vocal cord and adducts it, which means it brings the vocal cord to the midline. No other muscle to oppose its action, so both the cords remain in midline or adducted position. So this is how it is going to appear. So this is the epiglottis, the right vocal cord, okay, and the left vocal cord. They are very close to each other. When I ask the patient to take a deep breath, they will not move away. Or when we ask the patient to take a deep breath, they will be in adducted position, closed position, with very little space in between the two vocal cords, very little space for the air to go in. So the patient will be presenting with stridor. So vocal cords cannot move away or adduct when the patient takes a deep inspiration. The patient is going to present in stridor. and respiratory distress and may need an emergency tracheostomy. So this is the only case where the only combination of palsies which we are scared of, which can lead the patient to tracheostomy or even sudden death also if we don't act fast. So most of the cases the presentation will be like this. Patient has undergone total thyroidectomy. Patient has undergone total thyroidectomy. He has developed bilateral recurrent laryngeal nerve palsy. On the table, if you don't see it, the patient will be fine because the patient is lying down post-op. So he is fine. He walks. He may feel a little bit of shortness of breath. He may think it is because of surgery. He may go home. And the patient says, "I am able to talk well because both the vocal cords are in the midline. They can vibrate properly. So the speech is good in this case. Speech is good. There is no hoarseness. Speech is good. But suppose the patient develops some upper respiratory tract infection. So little bit of space, even that gets compromised. The patient is going to present with stridor, shortness of breath. The SpO2 is going to fall down precipitously, and you don't know why." Then you look at the vocal cord. They are very close to midline. You give oxygen supplementation to the patient. Doesn't work. You have to go for emergency tracheostomy. This is how a patient with bilateral recurrent laryngeal nerve palsy presents. Okay. Now, that was the Wagner and Grossman theory. Now let us talk about Semon's law because this is an important question. Wagner and Grossman theory to me makes better sense than Semon's law, but Semon's law has to be described. It says that Semon's law says that in lesions of the nerve, the abductor fibers means the fibers which move which cause the vocal cord to move away from the midline. Abduction means moving away from the midline. Okay, suppose this is the midline. Are affected first because they are phylogenetically evolutionary standpoint newer compared to adductor fibers, which bring the vocal cord to the midline. So what does he want to say? Suppose the nerve is getting damaged. It is having abductor fibers which are moving the vocal cord away from the midline, and they're also having adductor fibers which will bring the vocal cord towards the midline. The abductor fibers will get affected, will not be able to function. So when it cannot function, abductor fibers, the adductor fibers will not be getting affected here. So the adductor fibers will be able to function. When the abduction is not happening, but the adduction is happening, what happens? It brings the vocal cord towards the midline. Both the vocal cords will come to the midline. Now, what did he say? Why the abductor fibers are getting affected? Because they are phylogenetically newer. That is, from the evolutionary standpoint, it is understood probably that the adductor fibers were developed first, and as the evolution went ahead, abductor fibers developed later. Because the abductor fibers developed later, they will get affected first than compared to the adductor fibers. Adductor fibers will not get affected. So abductor fibers will get affected. So abduction is lost. So adduction remains. So the vocal cords will be close to the midline. So in the end, abductor fibers are gone. Adductor fibers remain. So the cord stays in an adducted position that is close to the midline, and thus causing stridor in cases of bilateral recurrent laryngeal nerve palsy. This is Semon's law. Semon's law is from a phylogenetic point or from an evolutionary point. The abductor fibers came recently. Adductor fibers were present since many millennia, to say. And so when the nerve is getting affected, the entire nerve does not get affected. The abductor fibers get affected. Adductor fibers remain. So adduction happens. Abductor fibers are gone. So abduction cannot be done. So the vocal cords come close to each other and patient may develop stridor. So thank you for the patient listening. So this is what I wanted to convey in the first part of this. In the next part, we will be going more clinically. Thank you.